Hello, my name is Frédérique Penaud-Liorca. I am a pathologist and a molecular pathologist. I work in a comprehensive cancer center, Centre Jean Perrin in Clermont-Ferrand, France, and I'm in charge of the molecular diagnostic platforms in my institution. Identifying which mutation contribute to cancer development is a key step in understanding tumor biology and developing targeted therapies. Gene alterations such as mutations, amplification, fusions that provide a selective growth advantage and thus promote cancer development are termed driver alteration. Those alterations that do not promote cancer development are termed passenger alterations. They are just the reflection of genomic instability. ALK gene is on chromosome 2. ALK gene is encoding a receptor tyrosine kinase, which belongs to the insulin receptor superfamily. The protein is a transmembrane receptor, so it has an extracellular domain, an hydrophobic stretch corresponding to a single pass transmembrane region, and an intracellular kinase domain. And this is the target for the targeted therapies. It plays an important role in the development of brain, and it exerts its effect on specific neurons in the nervous system. Sometimes this gene is rearranged, so there is a fusion with another gene. And in non-squamous cell lung cancer, ALK gene is rearranged in 5% of the cases. The ROS gene is on chromosome 6. It encodes a receptor tyrosine kinase, and we don't know exactly the physiological role in humans. We have chromosomal rearrangement resulting in ROS1 fusion in 1 to 2% of non-squamous cell lung cancer. And this is the main mechanism underlying ROS-driven oncogenesis. Most ROS1 mutation and amplification have an unknown significance, and dysregulated ROS expression is probably, at most, a secondary oncogenic mediator. So for ROS1, it's really the fusion that is important in oncogenesis. Those chromosomal rearrangements, they are the most common genetic alteration in those two genes, and they result in activation of oncogenic pathways that are important for proliferation, cell survival. So they are highly oncogenic. When we have a fusion gene, this is giving a receptor that is permanently activated, and it is leading to a continuous cell proliferation signaling, and it's also interfering with normal apoptotic cell signaling. So the receptors that have been coded by those fusion genes are highly oncogenic. ALK gene rearrangement occurs in 3 to 5% of adenocarcinoma, and ROS fusions in 1 to 2% also of adenocarcinoma. And they are very important because they predict response to ALK and ROS targeted inhibitors. The clinical presentation of patients with ALK and ROS1 fusions in non-squamous cell lung cancer is quite superimposable. So they are more frequently found in patients who are never smokers or light former smokers. There is a higher incidence in young patients, higher incidence in female patients, but maybe it's due to the smoking habits. And then on morphology, they are more frequently found in solid, acinar, cribriform, papillary carcinoma. So this is more found in the Asian population. And in the Western population, they also have another rare histology that is a signet ring pattern. And they express by immunohistochemistry TTF1 like many adenocarcinoma. So this is the classical clinical presentation. However, those clinical pathological features are insufficiently sensitive to screen for testing an individual patient, as significant proportion of ALK and ROS1 rearranged tumors may go undetected. And very frequently, we find those alterations in patients that are with another histology or who are like 60 or 70 years old. So that's why we don't use those clinical and pathological criteria alone for the selection of patients. What is for sure is that ALK and ROS1 rearrangement are very infrequent in squamous cell carcinoma. They have been reported in adenosquamous carcinoma. So those adenosquamous carcinoma is a mix of squamous cell carcinoma and adenocarcinoma. And those ALK and ROS1 rearrangement are largely mutually exclusive with EGFR or KRAS mutations. So for ALK, we have many drugs. Some of them we use for first-line therapy, like alectinib, crizotinib. Other that we use for a second option or for first line, like ceritinib. And then if we have a resistance, we need to rebiopsy or to perform a liquid biopsy to elucidate the mechanism of resistance. And in particular, we have a type of mutation in ALK that is found that is called the G1202R resistance mutation. And those ALK resistance mutation, they have different percentage of occurrence depending on the type of drug. We can also use other drug like brigatinib, for instance, or alectinib, and they target the effect of those drugs can lead to other mutations. So in the event of a first progression under a tyrosine kinase inhibitor, it's possible to adapt the treatment to the molecular profile of resistance if this is available, or we can switch to another tyrosine kinase inhibitors that was not previously used, that can be chosen from alectinib, brigatinib, ceritinib, or lorlatinib. For ROS1, the first-line treatment is usually based on crizotinib, and the second line on lorlatinib or entrectinib. Again, we have frequently resistance, and in 1/3 of the cases, there are resistance mutation, and the most frequent one for ROS1 is the G2032R. And also we have other out-of-target resistance mechanism, also for ALK, such as MET amplification. So they will guide potential treatment options. So we have several tools that we can use for testing for ALK and ROS1 alteration. We have immunohistochemistry, looking at the protein, so protein overexpression. In situ hybridization, looking at the rearrangement, or NGS. So the situation is different for ALK and for ROS1. For ALK, immunohistochemistry may be sufficient to establish the diagnosis, subject, of course, to compliance to the quality criteria of immunohistochemistry. So if we have a strong expression of ALK, in many guidelines, we say that we can consider that this patient has an ALK rearrangement. So it's what we call a 3+ by immunohistochemistry. It is nevertheless prudent because there is a non-zero risk of false positive to confirm the presence of the rearrangement by another technique, such as FISH or NGS. But a strong immunohistochemistry for ALK could be enough to select the patient for tyrosine kinase treatment. Of course, if it's a 2+, so a lower expression, or if it's a negative by immunohistochemistry, but if it's a non-smoker, a young patient, we will use another technique to be sure that we don't miss a patient with a rearrangement of ALK. For ROS1, the situation is different. In fact, ROS immunohistochemistry does not currently have the same performance, and it is not sufficient. So usually we use in parallel ROS1 immunohistochemistry and FISH, or ROS1 immunohistochemistry and NGS. And in the guidelines, it's very clear that platforms that cannot provide FISH or NGS must send the sample to other platforms, because we really need to have ALK rearrangement and ROS1 rearrangement status for the first-line treatment of metastatic non-small cell lung cancer. Right now, we consider that NGS is the gold standard, because we have many targets to look at in lung cancer, several mutations, such as the different mutation in EGFR, some specific mutations in RAS, alteration in ERB2, alterations that could be also potential resistance like MET. So, and also fusions in ALK, in ROS1, but also fusions in RET, in NTRK, in NRG1. So today, NGS is considered as probably the best option because it's an all-in-one test. So it's more or less the gold standard option. For NGS, we have two possibilities: broad DNA NGS or RNA sequencing. So in fact, if a large broad DNA NGS panel fails to identify drivers, we have to conduct RNA sequencing, usually it's targeted RNA sequencing, to maximize the detection of fusions, because we know that with DNA, we don't have the maximum sensitivity to detect fusions. So it's better to run also an RNA-seq for more specificity. We will use liquid biopsy in case of tissue insufficiency. If it's impossible to biopsy the patient, if the patient has a very low tumor content in the biopsy, so we will use liquid biopsy. And today, also the use of liquid biopsy is desirable when we want to monitor resistance, so at progression. And this will be, of course, very important as a first line diagnostic tool, in particularly in the non-smoking patient, to be sure that we cover all the potential targeted alteration in the non-squamous cell lung cancer. In fact, RNA today, with the huge number of targets that we have to screen for non-squamous cell lung cancer, now is considered, when it's accessible, of course, as the gold standard for the screening of those alterations in non-squamous cell lung cancer. And it's better to offer both DNA and RNA NGS. So for the first line treatment in metastatic non-small cell lung cancer, we must have at least EGFR status ALK and ROS1 status. And we need for the second line to have other biomarkers. So it's really something that we need to have at diagnosis. And then after progression, it's very important to be able to look at the resistance mechanism to be able to target the treatment, because we have options for the resistance cases. Unfortunately, for tyrosine kinase inhibitors, we know that in most of the cases we will have resistance, and those resistance can occur by different mechanisms. So one mechanism will be on target, so it will be through mutations in ALK genes or ROS1 gene, or it can be off target, meaning that it will be an activation of other pathway like MET, for instance, MET amplification, or it can be also sometimes a change in the phenotype of the tumor. By that, I mean that an adenocarcinoma will switch to a small cell carcinoma. And this will be the different mechanism of resistance to tyrosine kinase inhibitors. It's important to monitor and to diagnose that, because we know that the second generation, the third generation of tyrosine kinase inhibitors can be sensitive and can work for the patient with those resistance mutations to the first line treatment. Copy number alterations. At the beginning for ALK, we were thinking that copy number variation was, those alterations were thought to identify patients that may respond to ALK inhibitors. But in fact, today we have more and more data showing that it could be a mechanism of resistance. And for ROS1, copy number variation in ROS1 doesn't seem to have any impact on resistance or response to treatment. For the future, I think that ALK and ROS1 testing should be included in a targeted RNA-seq panel at diagnosis, and also for the screening for mutation and other markers at progression. And I think that this will be through NGS. So NGS on the tumor, I think it's important at least to have at the beginning of the disease an evaluation of the tissue, because we need also to have other parameters. So we need to have at least one biopsy of the tissue, also because we need to have PD-L1. So this is immunohistochemistry. We need to look at that on the tissue. But after, I think that liquid biopsy should be extremely a non-invasive tool that should be used more. And of course, when we don't have access to the tissue, or if it will take too long to get a tissue biopsy for a patient, liquid biopsy with a large NGS panel, a broad NGS panel, is also a very interesting option for our patients. I have started to test ALK and ROS1 now for many years, and we were doing sequential testing, so immunohistochemistry, then FISH, and we were doing PCR to look at KRAS, to look at EGFR, and then we had new biomarkers coming, and then we observed that NGS was becoming less expensive, also was available, at least in my country, in France, in many places, because we had an incentive from the government to install NGS platforms. So now I think that in a view of maximizing small biopsies, it's better now to start directly with NGS, with the exception of PD-L1, because PD-L1 we need to do immunohistochemistry. But for all the other biomarkers, we can do molecular biology. And the combination of DNA and RNA NGS is really for me now what should be performed, because it's really cost effective. And it's cost effective in many ways. It's cost effective because it helps us to have all the biomarkers at the same time. So it's also possible for the oncologist to foresee the second line or the third line of treatment, because some drugs are not available for first line. Not all the drugs are available as first line options. And it's also tools that now, as molecular biologists, we know well how to use them, how to interpret the data. So we are able to give the result within 1 or 2 weeks, depending on the complexity, or if we have DNA and RNA-seq at the same time, or first DNA sequencing and then RNA sequencing. But now it's really with very good timelines for the management of the first line treatment for the patient with advanced or metastatic non-small cell lung cancer.